Uterine cancer is the most common gynecological cancer in the United States, and it's rising. If you're a Black woman, you are twice as likely to die from endometrial cancer than a white woman. Because of racial bias, regardless of stage, Black women simply do not get guideline concordant care, which simply put, is just the recommendations for treatment. I know firsthand how endometrial cancer impacts women's lives. But don't panic yet. Endometrial cancer is often treatable and curable if caught early. Dr. Carol Brown, welcome to the show. I am so delighted to have this conversation with you because this is long overdue. But before we get into our topic, Carol, I would love for our audience to know a little bit about you. So you grew up in Los Angeles.
That's right. I grew up in Los Angeles, California, in an area of Los Angeles called View Park, which I think some of the podcast listeners may be familiar with. I think it was made famous on a couple of different TV shows in the past. But yes, and it was pretty unique because it was a Black community of middle class and upper middle class people in Los Angeles, and a lot of physicians, like my father was a physician, teachers, educators, lawyers, and within a really completely Black neighborhood, schools, stores, everything. So it was a really very unique, I think, upbringing, and really helped kind of set me up for success in the future.
Now, your father was one of, not just a doctor in the community, he was one of the first Black surgeons to open a practice in LA. So was that your influence? Was that your impetus for going into medicine?
I think, yeah, my impetus to going into medicine was definitely my father. And also, as I said, there were actually 3 or 4 Black physicians. Actually, all of them went to either Meharry or Howard Medical School, who lived on my street. And my best friends in my neighborhood's parents were physicians, and again, had attended historically Black medical colleges, because in those days, my father graduated from medical school in 1948. Ooh. So there were no options other than historically Black medical colleges. So that was definitely a huge influence, because not just my father, but my friends' parents, were all in medicine. And it was a way that I got to see an amazing career that allowed you to really interact with people and really give back to the community and really try to make a difference in people's lives. So that definitely influenced me for sure.
I want people to know a little bit about what GYN oncologists are. Now, you and I are both OBGYNs, so we did exactly the same training for 4 years, but after that, explain what a GYN oncologist is and what additional training you had to get to be there.
A GYN oncologist takes care of all the cancers that a woman can get other than breast cancer. So all the cancers of what are called cancers below the belt, the uterus, the cervix, the ovaries, the vulva, the vagina, all those cancers are cancers that a GYN oncologist takes care of. So our major training is using surgery to treat cancer, but we also are trained in other types of treatments, including chemotherapy and new types of treatments like immunotherapy and targeted therapy.
Now, that's very interesting that you said that you also do chemotherapy. Now, is there another surgical oncology specialty that does their own chemotherapy?
No, there actually isn't. And that's something that's very unique about GYN oncologists. What's also unique about them is, as you mentioned, GYN oncologists are trained, they have full training in the field of obstetrics and gynecology. They are fully trained OBGYNs. They could deliver a baby if they needed to.
When you're talking about the uterus, just run through the types of cancers that can involve the uterus, and what exactly do you do to screen for those, even when you're just talking about the ones that involve the uterus?
Sure. So when we talk about the uterus, which is the organ that, is also known as the womb, where a pregnancy is carried, It's made up of two types of tissue. One is muscle, and it's smooth muscle, not like the muscles in your arms or your legs. It is a type of muscle that can stretch and expand. So if the uterus is carrying a pregnancy, it can go from being the size of a pear to being the size of a watermelon, right? So that muscle tissue can give rise to cancers, but the more common type of cancer of the uterus comes from the lining of the uterus, which is what is present in order to support a pregnancy. And when a pregnancy doesn't happen, the lining is what is expelled or shed from the woman's body. So when you have your period, you're expelling or shedding your uterine lining, which then regenerates in a cyclical fashion. So the most common type of cancer that women can get in the United States and really almost also worldwide is cancer of the lining of the uterus. It's also called endometrial cancer. There's a third type of cancer that technically is a cancer of the uterus, and that's cervical cancer, because the cervix is what the opening to the uterus is called. It's part of the uterus. It's not a separate organ. It's made up of the same smooth muscle. The cervix, which the normal opening of the cervix is probably, about the size of a grain of rice, has to stretch to 10 whole centimeters, big enough for a baby's head to fit through. Mm-hmm. So there's a separate type of cancer called cervical cancer, which women can get, which is actually the most common type of GYN cancer worldwide.
Right.
So there are three types of cancers of the uterus. The muscle types of cancer, which is called sarcoma, not very common. The lining cancer, endometrial cancer, very common, and then cervical cancer.
So can you just run through really quickly, how would you screen and how would you know how would you screen for each of those types of cancer? Or can you screen for all of them?
Right. So the only cancer of the ones that we were talking about that there actually is a validated good screening test is cervical cancer. And that test is the pap smear. And all of our listeners should know what a pap smear is. It's where they take a sample, they scrape some cells off the cervix, look at it under the microscope, and look for changes that might mean cancer is there. So that's actually the only one that there's a screening test for. Thankfully, the other cancers are not so common and have, most of them, except ovarian cancer, have signs or things that you're going to notice that will lead you to getting diagnosed at a very early stage. So I'll talk very briefly about vulvar and vaginal cancer first, because those are very uncommon. But the bottom line is, if you have a nodule or a bump on your vagina or your vulva, or if there's itching or pain that is there and it's something new that you've noticed and it's been there for more than a week or two, then that's something you need to get checked out. Remember, vulvar cancer, vaginal cancer, they're basically types of skin cancer, very, very rare. But I can tell you that it's almost unheard of nowadays to have somebody not notice something that is very, very early for vulvar or vaginal cancer, because thankfully we as women are more aware of our bodies, in touch with our bodies. We look at our vaginas, we look at our vulvas, and I would encourage our podcasters, listeners to do that so that you know what's normal for you.
Right.
But for endometrial cancer, uterine cancers, there is no screening test, but bleeding, any type of change in your bleeding, heavy bleeding, or if you stop getting your periods, bleeding after your periods could be a sign of cancer. And then for ovarian cancer, that's the toughest one. We don't have great screening tests for that.
This is the same conversation that has been had probably for certainly as long as you and I have been trained. And we've not really made a lot of progress on screening, particularly for ovarian cancer. What is that? Is it just lack of research, lack of concern, or is it really just that difficult to come up with a screening test?
It isn't, I think, for lack of concern. For ovarian cancer, it's a disease that really isn't set up well to have a screening test. like breast cancer or cervical cancer, because it isn't that common. And by the time there's no direct connection with the outside world from your ovaries, right? You can't see them, you can't feel them. And by the time ovarian cancer causes symptoms, it's usually already spread. So the way the science is really advancing for ovarian cancer screening is early detection of just a few cancer cells or a few particles of DNA that may be circulating in someone's bloodstream long before the actual cancer becomes visible on a CT scan or imaging. So there are now even some marketed tests, but they're definitely, I think within the next 5 to 6 years, you're going to see tests come out on the market that can take a drop of your blood and screen for a variety of cancers, including ovarian cancer.
Well, I am happy to hear that, because I think that when I say lack of concern, I don't mean lack of concern in doctors, but in terms of where the research and research dollars are going to finding this DNA or these screening tests. But I want to get back to the Pap smear for a moment, because the Pap smear has been probably, I think, one of the most important screening tools that we've had in gynecology. Every woman understands Pap smear. That's how they think of going to the gynecologist. They don't say, oh, I need my exam. They go, I have to go get my Pap smear. Okay, great.
Yes.
That's a success.
Absolutely.
But my problem is that I understand that the science evolves and you probably don't need a Pap smear every year the way we have been testing. But my fear is that when you say every 3 years or every 5 years on a Pap smear with HPV screening, that women are going to take that as, oh, well, I don't need a Pap smear. I don't need to go.
Absolutely. You're absolutely right. I mean, I've spoken about this ever since they changed the guidelines. And I think that, the OBGYN and medical community and public health community did probably over 40 to 50 years of work to get the Pap smear so ingrained in our culture of healthcare that, exactly as you said, women say, I need to go get my Pap smear. So sending messages about, oh, you only need it every 3 years. And then even worse is the message that if you're over, I think it's 65, and you've had 3 negative consecutive ones, you don't need to get it anymore, which is absolutely ridiculous. Because why is that ridiculous? Well, that is based on the erroneous assumption that we women of a certain age stop having sexual intercourse.
Right.
Or sex of various types when we're over 65, which at the time those guidelines were drafted, that's what assumed. And the reason that's important for the audience to understand is that cervical cancer, among some other cancers, is caused by human papilloma virus, which is a sexually transmitted infection, but not a sexually transmitted disease. And so if you continue, as we all hope you will, to be sexually active into your 60s, 70s, 80s, and, we're living into our 90s now, you're still at risk of getting cervical cancer. Cervical cancer can be and is being wiped out and completely prevented because there is a vaccine called the HPV vaccine. It is now approved for men and women up to age 45. It protects against 9 different types of human papilloma virus. So it doesn't just help prevent cervical cancer. It helps prevent anal cancer, mouth, head and neck cancer, some types of esophageal cancer. This is a game-changing, unbelievable scientific breakthrough. And there are countries in the world, including Australia, including Rwanda, who have instituted mandatory HPV vaccination for school-age girls and have literally almost completely eliminated cervical cancer in their populations in the entire country. So I want women to still go get their pap smears, but I also want women and men and everyone listening know that you can get a vaccine which will prevent you from ever getting cervical cancer and prevent some other types of cancers that are caused by HPV.
Let's underscore, if you are under the age of 45 and you have not had an HPV vaccine, please talk to your gynecologist about getting one. And please make sure that your children are vaccinated with the HPV vaccine.
And make sure that the males in your life are also vaccinated.
And this is a message that we've really got to get out there, because in the current environment and so much vaccine hesitancy and the misinformation about vaccines, this is the one clear success story that we've had. So please, let's not sleep on that one.
Absolutely.
So let's talk about endometrial cancer, or cancer of the lining of the uterus. Who gets it? And then what are the types of endometrial cancer that you can actually get?
So I think the most important thing for our listeners to understand is that endometrial cancer has replaced ovarian cancer as being the biggest threat to women's lives, even bigger than breast cancer, all right, because it is more deadly than breast cancer. And this is because over the last 10 to 12 years, the number of cases of endometrial cancer in the United States have skyrocketed. It's as if there is an epidemic. And the age at which women are developing this cancer and showing up with this cancer has gotten about a decade younger.
Okay, so what was it before? What was the average age 10 years ago?
Right. So when I went to medical school 30, 40 years ago, the average, it was a disease of women in their 70s, late 60s and 70s, who were definitely postmenopausal, were older. It was a disease associated more with women of Caucasian racial background. Now we are seeing this cancer. I would say the peak age is in the 50s, late 40s. We are seeing so many cases in women who are still getting their menstrual cycles, and even in young women. The number of cases is rising like 7 to 10,000 more per year in the United States. And it is much more common and unfortunately more deadly in Black women than it is in white women in the United States. We still use the term Black, but as scientists, we've really changed that to look at race as ancestry, because we can look at people's genetic ancestry, whether they come from the African continent, Asia, European, South American. So that's how we talk about it. Women of African ancestry are more likely to get these aggressive types of endometrial cancer, and also to be diagnosed at a younger age.
Yeah, I want to get back to something you said earlier, is that, sort of what our view was of the typical patient who had endometrial cancer back when you and I were in med school versus now. And is not part of it the fact that they thought that Black women had less uterine cancer because they had fewer uteruses to get cancer in? So many Black women had hysterectomies. And certainly back in the 70s and 80s, I think it was upwards of 50% of Black women never even made it to menopause with a uterus for various and sundry reasons. And that's another show too. But now, when you look at that data and you correct it for, okay, let's look at everybody here. And now it says that Black women have a higher incidence, certainly higher than what we thought, but they're surpassing that prototypical white elderly woman who was thought to be at risk for endometrial cancer.
That is absolutely true. And there was a landmark paper published a few years ago that went back and corrected the data, the statistics about endometrial cancer in the past for how many women had had hysterectomies. So you're absolutely right. The fact that so many Black women in the past, I think it's not happening so much now at all, which may partially explain why we're seeing so much more cancer in Black women. But Black women were having their uteruses removed for a variety of reasons that we would never do today, right? And another thing that I think also dealt with it is women having their tubes tied. Because having your tubes tied or having part of your fallopian tubes removed actually will decrease your chances of getting both ovarian or endometrial cancer. So that may have accounted to it as well. But it's definitely true that now that this, taking somebody's uterus out just because they had a heavy period, which used to happen all the time if you're Black, all the time, or wouldn't even tell you, or we're going in to do something else and they take out your uterus, that doesn't happen anymore. One of the major symptoms or some of the symptoms of endometrial or uterine cancer is bleeding, heavy bleeding, painful periods, bleeding in between the periods, and even bleeding after your periods have stopped. And there are dozens of studies and experiences that all of us have had that we know that when we as Black women have female problems or complain of problems with our reproductive organs, we are victims of having our symptoms minimized, our concerns dismissed. We are more likely to be told, oh, that's just female trouble, or oh, you're perimenopausal, or oh, you probably have fibroids, without doing any testing to look at it. And that, unfortunately, is still going on today. And I think one of the main things I hope that we can let the audience know from this podcast is the importance of advocating for yourself. When you know something is different and when you know something is wrong, you may have to go to another provider.
I think part of the hesitancy that Black women have sometimes even about complaining about things is it's almost as if we've been indoctrinated into thinking that, oh, well, suffering that's just all part of womanhood. We sort of take it on. You don't even think of it. You don't think to bring it up because it's just been one episode of suffering after the other.
Because of this rising incidence in endometrial cancer and because of the disparities experienced by Black women with endometrial cancer, we've created a special program of awareness and diagnosis called the Endometrial Cancer Equity Program, specifically because of what we're talking about. In my 35 years of practicing genuine oncology, I have seen so many women, especially Black women, whose complaints and concerns, particularly about bleeding, have been minimized to the point that I'm horrified.
If we were going to say, what are the signs and symptoms when we're talking about endometrial cancer, bleeding is chief among them.
Yeah. So I would say if you are over 35 and you're still getting your periods and you have a change in terms of you start having very heavy flow, you start passing clots, you have bleeding in between your periods, that could be a sign of endometrial cancer. If you know that you have fibroids, and they're getting bigger, or your doctor says, I think you have fibroids, but they're not really sure they're fibroids. These are some of the things in younger women that you need to be aware of. And in women in their mid 40s, early 50s, again, before they stop having their periods, really, again, this change in your bleeding pattern. I don't even want to label it as abnormal because it's abnormal for you. It's different for you. And this is where advocating for yourself, keeping track of your menstrual cycles, keeping track in your own mind of how much bleeding you do so you can recognize when something is different. And what you may need to do is say to your OBGYN or your nurse practitioner that takes care of your gynecologic issues, this has been happening and it's probably not this, but I'm worried I could have endometrial cancer. And so what may be done at that point is to do an ultrasound, or more importantly, and this is a something I'd like the audience to take away. If you are over 35 and you have abnormal bleeding like this, most women need to have a biopsy done of the lining of the uterus to make sure they don't have endometrial cancer. And so it's not a screening test, but it is a test that, you may end up needing to have in order to make sure that that abnormal bleeding is not due to endometrial cancer.
Every year, as New Year's approaches, my family and I have a little ritual. We pick a place where we can step into the new year with intention, somewhere peaceful, somewhere that lets us close the chapter on the past 12 months and welcome the next with open arms. This year, we chose a quiet lakeside town. We wanted space to gather, cook, laugh, and stay up far too late, talking about the year behind us and the one we hope to build. As we settled into the home we booked on Airbnb, lighting candles, chopping vegetables, and putting on the playlist my kids tease me for, I looked around at the people I love most. There's something grounding about being together in a place that feels warm and lived in, especially as the calendar turns. And I found myself thinking, while we're here making our own New Year's memories, someone else could be enjoying our home and starting their year with a fresh sense of possibility too. Your home doesn't have to sit empty while you're away. It can become a gathering place for another family, a place to cook their first meal of the new year, to share their resolutions, to rest, reset, and step into the next chapter with hope. And the extra income you earn from hosting, it can help support the things you want to bring into your own life in the new year. Another trip, a long-awaited project, or simply a little more breathing room in your budget. Your home can help someone else start their year on a beautiful note and help you reach your own goals too. Your home might be worth more than you think. Find out how much at airbnb.com/host. You know, the new year always invites reflections, what we want more of, what we're ready to let go of, and what we've been putting off. So many of us have great ideas, real skills, something meaningful we could build. But ideas only change your life when you decide to act. January is short. Don't let February arrive with the same old story. If 2026 is the year you step into who you're meant to be, the most powerful move you can make is starting your own business with Shopify. Shopify gives you everything you need to sell online and in person. Millions of entrepreneurs have already made this leap, from household names to first-time business owners just getting started. Shopify makes it easy to build your dream store with hundreds of beautiful, customizable templates. Setup is fast with built-in AI tools that help write product descriptions, headlines, and even edit product photos. Marketing is built in with email and social campaigns that reach customers wherever they scroll. And as you grow, Shopify grows with you, handling more orders and new markets, all from one dashboard. In 2026, stop waiting and start selling with Shopify. Sign up for your $1 per month trial and start selling today at shopify.com/second opinion. Go to shopify.com/second opinion. That's shopify.com/second opinion. Hear your first this new year with Shopify by your side. All right. So, Dr. Brown, the words that no one ever wants to hear is you've got cancer, but you've been diagnosed. How is endometrial cancer treated? What are your options?
So there actually are a lot of options for treating endometrial cancer, including options for younger women who haven't finished having children or for whatever reason aren't ready to have a hysterectomy. So it's important, if you're a younger woman and you haven't finished having children, or you're not ready to have a hysterectomy or surgery to remove the uterus, there are options to treat endometrial cancer that's very early, actually with hormones. And you treat it for a period of time in order for the woman to kind of temporarily go back to normal, have a baby, and then move on from there. But the main way that endometrial cancer is treated is by surgery to remove the uterus, the tubes, and the ovaries. That's commonly known as a hysterectomy. There are ways of doing this surgery that minimally invasive, or they're done through very small incisions so that you don't have a lot of downtime. You can go home even the same day or the next day from the surgery. But surgery to remove the uterus is the main way it's treated. And then if the cancer has some things about it that mean there's a high chance it might come back, if that's the situation, then you might add on radiation or chemotherapy to the surgery. But most endometrial cancers can be treated and cured with a hysterectomy.
I would just want to follow up on that. You said that for women who either want to preserve their uterus, or sometimes you're just not well enough, for elderly patients who aren't good surgical candidates. You said for hormones. What hormone treatment would you use for them?
The hormone progesterone, which comes about in the second half of your menstrual cycle, basically sends a signal to the lining to kind of break down and stop growing and stop proliferating. So we treat the lining with progesterone. And one of the most effective ways of doing that is to use an IUD that secretes progesterone and put that into the uterus. And that way you're delivering the progesterone right to that uterine lining that has cancer in it or precancer in it. And over a period of months, it's usually a total of 6 to 9 months of treatment, it can cause, in some cases, that lining to go back to normal. So it's treatment with progesterone. It also can be taken by mouth, but it is very effective to actually have that IUD, progesterone secreting IUD, placed.
And let me give our audience some good news here. An early diagnosis of endometrial cancer is treatable and curable, which is why it's so important that you know what to do and what to ask for. It's only a problem when it gets ignored and you come in with later stage disease. But tell me, why is it that you think that despite all of that Black women do so much worse with endometrial cancer?
There's a two-part answer to that question. The simplest part of it relates to what we've just been discussing, that Black women's symptoms and experiences with their bodies tend to be minimized, ignored, and that they are diagnosed later because they are not taken seriously until later on in the disease, or they don't have access to regular medical care. They don't have access to a GYN provider, whether that's a nurse practitioner or whether that is a physician. And so that is part of it. But part of it is actually that Black women tend to get biologically different types, more aggressive cell types of endometrial cancer. Actually, myself and some of my amazing scientific colleagues here at Sloan Kettering actually did one of the first studies to look at the DNA makeup of Black women with endometrial cancer and compare it to the DNA of white women and other women with endometrial cancer. And when I talk about DNA, I'm talking about the DNA that we are all born with, that we inherit, the genes from our parents. But more importantly, I'm talking about the cancer's DNA, because the cancer is a vibrant, plastic, developing thing. It can change, it can mutate. And so what we found is that the cancer DNA profile, the genes of the cancers of Black women compared to white women, were different. They had a particular gene that we found was more likely to be mutated in Black women with a certain cell type than in white women. And it turns out that this gene, if you have a mutation in this gene, you're less likely to respond to a certain type of treatment. And there are discoveries like this happening in colon cancer, prostate cancer, triple negative breast cancer, lung cancer. These are all major cancers experienced by people in the United States where there is a glaring disparity. Black people do worse with all the cancers I mentioned. And we are now so blessed that we can unravel the molecular genetic code of their cancers. And we are seeing this in all of these cancers, that Black people have actual genetic, molecular biologic changes in their DNA.
Right.
And that are accounting for this.
Right.
So that's part of it too.
And let me say, because I want to be clear about this, it's not the fact that Black people necessarily have cancer genes, and that's why it is. And what Dr. Brown is really saying is that it is the effect of stress, how we live, what we eat, the effect that it has on your existing DNA. Certain genes are turned off, some are turned on, some are get, screwed up by the lives that we lead. And that's why we can't take stress out of the equation. And, Dr. Arlene Geronimus, who is a psychologist at the University of Michigan, really talks about this concept of weathering and how you live. It's not necessarily, you can't say to Black women, oh, you have more of this, more of this, more of that. What is wrong with you? The better question is, what are we doing to you that is causing these things to express themselves? So, understand when we talk about genetics this way, they may or may not even be hereditary. That's the thing. It's damaging the DNA that you are dealing with on a day-to-day basis. One of the things that we talked about a lot that is through line for this is obesity. Okay. Yes. And of course, the rates of obesity are going up in this country for everybody, not just Black women. Everybody's getting, more and more so. So here's a question. What do you think about GLP-1s as a mitigating factor for diseases that may be obesity related, like endometrial cancer?
So I think that GLP-1s, we're getting more and more evidence that they can help with the treatment of many chronic diseases, including cardiovascular diseases, kidney disease. And, we already know that women who have either had endometrial cancer or have endometrial cancer who engage in regular exercise are less likely to have a recurrence, are less likely to develop endometrial cancer in the first place. So there are studies that are ongoing now to try to see if treatment with GLP-1s, including, and in specific, the weight loss, and this is for people who are, meet a certain criteria.
Right.
And I want to be clear about that.
Right.
That if the weight loss that's associated with using GLP-1s will also decrease their risk of endometrial cancer ever developing, I think that I am sure we will see that, and we've already seen, as I mentioned, with cardiovascular disease, kidney disease. I am sure we are going to see for a certain type of endometrial cancer, the type that is estrogen related, the type that is more curable, that's usually found in an earlier stage. I am very confident that GLP-1 use will be associated with a decrease in that type of cancer.
I love this. You see, you and I are on the same page here, I love that. All right. What about oral contraceptives?
Oral contraceptives are amazing. Oral contraceptives prevent 2 or 3 different types of GYN cancers. Taking oral contraceptives for 5 years cuts your risk of getting ovary cancer by 50%. And also using an IUD, a progesterone secreting IUD, also reduces your risk of getting endometrial cancer, probably by 70 or 80%, and of getting ovarian cancer. So,
exactly. And let's say that again, because I don't know what's afoot, but there is this thing that's going on out there. They're saying like oral contraceptives, they're horrible, they're evil. And I'm like, no, they're not. And we have more experience with oral contraceptives than we have with just about any other medication that's out that women have been using continuously. So, all right, understand this. All oral contraceptives are not bad. Everything is not for everybody, but if they work and you've got contraception in lighter periods and decrease your risk of ovarian and endometrial cancer, I don't see what's not to love. What about you?
I agree.
Okay.
I absolutely agree.
What about the use and the decrease, I should say, in the use of menopausal hormone therapy, or HRT, because it plummeted after the Women's Health Initiative. And, as is always the case, it plummeted for everybody, and Black women are the least likely to use MHT or HRT. So what do you think that relationship is?
So I think that is another piece of the puzzle as to why the number of cases of endometrial cancer have risen. When you actually overlay the graphs, the decrease in the use of hormone replacement therapy corresponds to the rise in cases. Why? Because the hormone replacement therapy that women were taking was two things. It was estrogen and progesterone. And that progesterone is what helps prevent endometrial cancer. It combats the effects of estrogen on the lining. So in a postmenopausal woman, taking some progesterone along with the estrogen actually was preventing her from getting endometrial cancer. So what happened was, when all those millions and millions of women suddenly stopped taking estrogen and progesterone, the excess estrogen that they had floating around in their systems because of being overweight just had a free rein to hit their uterus and cause endometrial cancer. It is an actual direct relationship. So I'm glad you brought that up. We also know that if you've had endometrial cancer and you've had a hysterectomy, taking estrogen replacement therapy to alleviate your symptoms of hot flashes, vaginal dryness, everything, is not going to increase the cancer coming back. It is safe. We have shown that with studies, and it's beneficial in terms of your well-being, bones, all of that. So yes, very important.
Okay.
Hormone replacement therapy has been given a bad name for an invalid reason.
I hope everybody heard that, because, this is why I go to the experts for this. Dr. Brown, this has been fantastic, but before you go, I want you to tell me, what do you feel most hopeful about? And do you think that we have the biggest opportunity to really address some of these disparities and to decrease this cancer risk?
I am the most hopeful about the new ways of treating cancer that are personalized or designed to address the individual's cancer DNA. And these are called targeted therapies or immunotherapy. We have learned that your immune system can be an amazing weapon in your body's ability to fight cancer. And there have been many therapies that have been developed to help your immune system attack cancer cells specifically. And there are even some therapies that can be designed to help your immune system recognize your own individual cancer. And this has revolutionized a variety of cancer treatments, but specifically in endometrial cancer, specifically in Black women who, remember I said they have that more aggressive type and they have certain signals in their cancer. Well, those signals that are more common actually mean that Black women's endometrial cancer may be more likely to respond to treatment that helps their immune system revved up. We have seen remarkable, amazing cures, treatments of very advanced endometrial cancer with immunotherapy and targeted therapies. And these are different than regular chemotherapy because they really act just on the cancer cells and they use your immune system to help destroy the cancer. So I am extremely hopeful. And what we want is for Black women and all women to get the information about their cancer. You have to ask to get the testing done. You have to ask about clinical trials. You have to ask about these new types of therapies in order to benefit from them.
Now, everybody, after they hear this episode, everybody's going to say, oh, if they have a problem, I want to go see Dr. Brown. Okay. But for those who can't see you personally, what resources and recommendations do you have for them? And are there studies that they can sign up for?
Sure. So I would say to start with your OBGYN, and you can go over your risks for ovarian cancer, endometrial cancer, cervical cancer with them as part of your well woman checkup. You also, and included in that is talking about your history of bleeding, fibroids, etc. I think I say this to everyone, if you've been diagnosed with cancer, have a suspected cancer of the GYN organs that we talked about, you want to see a gynecologic oncologist. There are GYN oncologists everywhere, right? It doesn't even have to be at a specialized cancer center like I work at, but you want the opinion and the benefit of that special training that we talked about. And you want to ask about clinical trials if you've been diagnosed with cancer. Those are very important things. Also, the American College of Obstetricians and Gynecologists, which is an incredible organization for women, advocates for women, women's health, has a variety of information available online about cancer risk, bleeding, as well as the Society of Gynecologic Oncology, which I was privileged to be the president of. We have a website that has information about cancer risk and what you can do. So there's a lot of things out there, but I would say the most important thing is if you've been diagnosed with a GYN cancer or suspected GYN cancer, insist on seeing a GYN cancer specialist to get an opinion.
Absolutely. Dr. Carol Brown, thank you so much for being here. This has been a wonderful conversation, and I think that so many of our listeners are going to leave here knowing a lot more than they did when they started. So thank you.
Thank you so much, Dr. Malone.
It's time for the last part of the show where I give my doctor's orders and leave you with takeaways from today's conversation. Number 1, here is one more reason to maintain a healthy weight. Being overweight is one of the most potent risk factors for developing uterine cancer. Number 2, know your family history. Although most cases of uterine cancer are not genetic, some are. Number 3, report any postmenopausal bleeding to your doctor immediately. For pre- or perimenopausal women, also investigate any unusually heavy or irregular periods. If you have fibroids, simple screening tests like transvaginal ultrasounds or endometrial biopsies may not be accurate. If bleeding persists, ask for a hysteroscopy and directed biopsies. Number 4, for more details and links, be sure to check out our show notes for the episode. Keep joining in each week on YouTube or wherever you find your podcasts as I break down complex medical issues and leave you with expert advice. If you enjoy the show, follow us so you never miss an episode. And if you like what you hear, leave a review. Until next time, take care.